I welcome all of you to this much awaited afternoon session, which is the question and answer session with our pediatric tuberculosis experts. Rohit, can you put the slide, please? Yeah, so this is a 1 hour Q&A session, and we have esteemed tuberculosis experts and panelists, so expect all your doubts to be cleared. We have as our experts Dr. Varinder Singh. Dr. Varinder Singh, yeah, sir really doesn't need an introduction. He's Director Professor of Pediatrics at Lady Hardinge Medical College and Kalavati Sir and Children's Hospital, one of the top respiratory specialists of the country. Dr. Sangeeta Sharma, ma'am is Head Department of Pediatrics at National Institute of Tuberculosis and Respiratory Diseases, New Delhi, and in charge of National Center of Excellence for Pediatric TB and drug-resistant TB. And Dr. Ashwini Sood, Sir is Professor and Head Pediatric Medicine at IGMC Shimla. I welcome all the three esteemed panelists. Our moderator for the session is Dr. Ankit Parakh, and I request Dr. Varinder to please introduce Dr. Ankit Parakh. Thanks, Dr. Varinder Singh.
Thank you, Dr. Tabisha. I hope I'm audible.
Yes, sir, you are.
You're not visible, sir.
Okay.
What about me? I'm okay? My voice?
Yes, everything
Yes,
fine.
sir.
Okay, okay.
So it is indeed my pleasure to introduce Dr. Ankit Parakh. He is a man who has many, feathers in his cap. So he's a TB specialist, he's a chest specialist, he's a sleep specialist, he's an allergic specialist, and has been trained at several. I think he's more known in UK than in India because he has trained in almost 3-4 organizations there. And I had the good opportunity to have worked with him when we were together in the same unit, and I very fondly remember those areas. And I think he's the new star in the sky to be watched. So I'm glad that he's moderating this session today. Over to
Dr.
you.
Please screen share, Dr. Ankit.
So a very good afternoon to everyone, and thanks to the PCNI team for giving us the opportunity to deal with common questions on pediatric tuberculosis. I have made a few questions which usually we are asked. So we will take up those questions in brief, and then we can take up any questions from the audience as well. So let's start with a case. So this is a 10 years old girl who has fever, cough, anorexia, and weight loss for the past few weeks, and X-ray which is here, right? So we do a sputum smear examination. You find that the sputum smear is 3+. So the question is that with the clinical background, fever and cough more than 2 weeks, a presumptive TB with weight loss, which is possibly significant, an X-ray, which you have in front of you, and a microbiology, which is positive. Do you need anything else to, start this child on ATT? So the first question is that, do you think any further investigations are required? So Dr. Singh will take up the question further, that do we need any further investigations? Is sir there?
He's there.
Dr. Varinder?
He's not seen at the moment in this.
He's probably having some problem. You can ask questions to the next speaker.
Okay. So Dr. Sangeeta, do you think any further investigations are required, or we are done? We can put this child on ATT. You're not audible, ma'am. Please unmute yourself.
Yeah. So had it been, say, a few years back, I would have said start ATT. But that is not the scenario right now, because we have got such good rapid diagnostic tests tests available which tell us about the sensitivity of the known index case. So we would like to go ahead with those tests and get the ATT as per the resistance pattern of the child. Because the child is sputum positive, so you don't need anything else except first and second line LPA. Because those tests, they are done when the sputum smear is positive and they guide the further management. And this, the more efficient detection of MTB, that has led to detection of resistance upfront. And what we are offering now is universal DST. That means for any child who you start ATT, you know at least resistance to rifampicin, and in the future, probably to almost all the antitubercular drugs. So this is what you call as universal DST. Rather than starting ATT without getting tests done, you need to at least offer the child rifampicin resistance or sensitivity test that is available by first line LPA. And goals have now come near with all these tests available. The scenario and management of pediatric tuberculosis has changed over the years. Over.
So just to summarize here, that now we have a concept of a universal DST, which means that any child who is being diagnosed as tuberculosis is going to be tested. So one, you want to get Mycobacterium TB to confirm that yes, it is tuberculosis. And second, you want to get the resistance pattern, and the minimum is the resistance to rifampicin. So which means every child should be tested for rifampicin resistance. And Dr. Sangeeta will elaborate on what test we can use for getting this rifampicin resistance.
Yeah, the tests which are available, the tests which are available under the program and in our laboratories in our country are as follows. That is, we have NAT, that is nucleic acid amplification test. These are either it is cartridge based, that is called the CBNAT RIF. That means it would tell you just rifampicin resistance. In future, we are also expecting CBNAT XDR. That means in that same cartridge, not only for rifampicin, also further sensitivity to INH and fluoroquinolones and second line injectables will also be available. But that is a test which is already available in some countries, but not in our country because validation is occurring. The other is the TrueNAT. TrueNAT is the chip-based test. That is all NAT, it takes 2 hours. So the turnaround time is very important. Both CBNAT, RIF, and TrueNAT, they detect rifampicin resistance, and they can be done on paucibacillary samples, on extrapulmonary TB and pulmonary TB samples. Now coming to the next, that is the molecular testing through the line probe assay. Line probe assay, there are 2, that is first line drugs, that is rifampicin and INH, that is called first line LPA. Then the second line LPA is which detects the class resistance to second line injectables and the fluoroquinolones. And the results for this, they are available within 2 to 3 days. Maximum is 72 hours. The third in the pipeline is, especially for the smear negative patients, is the liquid culture. Now, the liquid culture has an advantage over the solid culture. Solid culture in ages, you must be remembering it used to take 6 to 8 weeks and further 6 to 8 weeks for the sensitivity. But with liquid culture, the results are available in 2 to 3 weeks as positive. But for a negative test, you need to wait for 6 weeks. So that is the reason 42 days is written as the upper limit, because you have to wait for a negative culture to be declared as negative for 42 days. So this is the order of preference of the test. And under the program, what if the patient is positive by any of the methods, the child is labeled as microbiologically confirmed. It is not bacteriologically confirmed because we are using molecular tests. So it is microbiologically confirmed. And under the program and in our country, we are offering, as we have already discussed, universal DST. That means for all patients, at least you need to know the resistance to rifampicin and in the future resistance to all the drugs. So presently, new patient, at least rifampicin, and for a patient who has had prior ATT, that is a presumptive DRTB patient, you need to get other tests for sensitivity to fluoroquinolones and second line injectables. So this is how these tests are there. I would just like to add a quick, there are two more tests because maybe the house must have heard about it. That is the LAMP. TB LAMP is a point of care test which is going to in future maybe replace smear, sputum smear. So it can be taken to the patient's house and the tests, they are available in less than 1 hour. And the other which is validated for HIV is urinary LAM. That is lipoaminomannan assay. That is for HIV, diagnosis of HIV patients. So these are all the tests which are available. Ankit, thanks.
So just to again summarize, this child was sputum positive. So this is the reason why ma'am said that you can do an LP upfront. I'll show you the new algorithm. The gene expert or the CBNAT or the TrueNAT is the usual test which you do as per the program. But yes, if a child or an adult is smear positive, you can put an LPA because CBNAT, the yield is something like 50 to 100 bacilli per around 100 bacilli per ml. If you're using a gene expert ultra, it comes down to even less than 20 bacilli per ml. Although the LPA is not as sensitive, and hence you do not do LPA if someone is smear negative.
Yeah, because LPA, it requires minimum 10,000 bacilli per ml, to be positive. So that is the cutoff for smear positivity. That is why we say LPA, get LPA done if the patient is smear positive.
So, Dr. Singh has joined back.
Yeah, there's one concern. This CBNet is available at most of the places.
Yeah.
If you come to the subdivision, so I think that should be the first message.
Yes, agreed.
It will depend upon the availability whether we have got LPA or CBNet. So because CBNet has now become a universal one. So yeah. First, as you discussed,
CBNet, even TrueNAT is available.
Yeah,
and it's available free of cost to the patient under the initiatives. So even the private labs, they are reimbursed through the government.
So Dr. Singh has joined back. So sir, can you take us through the new algorithm for pediatric tuberculosis?
Okay, thank you, Ankit. I had a connection failure, but I'm glad that I've been able to come back. So if you look at the current new algorithm, what's new? A disease which is so ancient and we have been treating for close to 100 years, what's going to be new in its management is a question which often comes to our mind. What makes new is always either a new test, of which we heard from Dr. Sangeeta and Dr. Sood, but also is the fact that we learn from our mistakes, or we sharpen of what we understand of a disease. So what has come in the new algorithm is that earlier fever, cough, any chronic fever, cough, and the definition of chronic was left to individuals, and we did not know what was a weight loss at which the possibility of TB would increase. So the current guidelines have kind of characterized them a little better. They say persistent fever for more than 2 weeks without a known cause. So that whole description classifier is important. Unremitting cough for more than 2 weeks, 2 weeks or more. So it's an unremitting, not something which comes and goes like a reactive cough, is more likely to be TB. It's not that other presentations cannot happen, but less likely. Likewise, you have weight loss of 5% or no weight gain in past 3 months despite adequate nutrition. So it's not a nutritional failure or failure of a nutritional rehabilitation in a child with SAM. One has to think of infections, and one of the infections you think of is pediatric TB. This, if it happens in presence of a contact or exposure to pulmonary TB case or a chest TB case in past 2 years, it becomes more likely, because if you are exposed, you are more likely to be infected, and if you are a child, you are more likely to develop disease faster as compared to an adult after getting an infection. So that's where the role of contact comes. The classifier of the symptoms remain irrespective of there being a contact or not being a contact. In presence of contact, the possibility increases. So this is what we call as, earlier the terminology used was suspect TB with these. Now we do not use the word suspect because suspect puts the burden on the victim as if they have committed a mistake. This is what we call as a presumptive case of TB, that you presume they may have TB. So once you have this presentation, then what is the next step to be done? If again we go back to the past, what would you commonly order? If you were working in a hospital like mine or Sangeeta's or Dr. Sood's, the resident would write GA for AFB into 2 days, tuberculin skin test, and a chest X-ray. One all together. Is that the right way to go about? TST, if there is time, we'll discuss, has lost its importance in current times with better tests available, very limited role. GA for AFB for yield was less than 10%. Getting a gastric aspirate was difficult. Most of our friends outside in the practice would not do it. Chest X-ray is what was required. So therefore, today we will do a chest X-ray first. But then if it is chest X-ray first, in the opening case, Dr. Ankit showed us a child who not only had a chest X-ray, also had a sputum. We were not happy with it. Then why is it this screening test says check chest X-ray first? We say that because here we are using chest X-ray as a screening test. And what do I mean by that screening test? I will elaborate as we unfold this algorithm little more. So on the chest X-ray, you could have X-ray findings. They can be highly suggestive being if you have a miliary TB, if you have hilar or paratracheal lymphadenopathy, or you have a chronic fibrocavitary disease. Chronic comes from history and fibrocavitary comes from the picture that you have cavitation, you have some area of atelectobronchiectasis, that's fibrocavitary. And in this case, depending on the type of respiratory sputum which is specimen which is available to you, it could be a self-expectorated sputum. In a smaller child, because they will swallow, it could be a proxy specimen like gastric aspirate or gastric lavage, or it could be an induced sputum if this child is not coughing a lot, and you could induce by giving 3% hypertonic saline after priming with salbutamol and aspirate that, and use that for a molecular test. So in the past, we were doing AFB. Today we do not suggest AFB as your starting test, simply because knowing that it is MTB is not enough. Even there, these tests perform far better. If your average yield was about 10% with sputum, it will go up to about 30-35% with NAT. Higher in older children, higher in patients who have parenchymal lesions, maybe the yield will be much more. Now, the cost of a AFB and the ease of AFB made it easier to ask all of these together. But however, the cost of a NAT is huge. And therefore, studies have shown if you have a chest X-ray which is normal, and since you have not seen the chest X-ray, if you order the chest X-ray and gastric aspirate together to begin with, you do not know what proportion of these symptomatics would have a chest X-ray abnormality. And therefore, you would test and get close to about 5 or 6% positivity. But if you go, those who have chest X-ray abnormality, it goes up to about 40%. So that's a substantive increase. And that is why now chest X-ray is used as the screening test to direct where you should be focusing your energies to get a respiratory specimen, which in children sometimes is difficult. One has to go for a gastric aspirate or sometimes an induced sputum, and use a test called like NAT, which is nucleic acid amplification test. Again, 3 types of NAT are available to us. We heard about Gene Expert, often called as cartridge-based NAT, which takes about 2 hours, but then there are 4 cartridges which can be run together. So if you have large number of samples, machine takes 2 hours, but you may be in queue for 3 days or 5 days. So if you send unnecessary specimens, you will lose that advantage. The other test is TrueNAT, made in India. It's a chip-based test, 2-step. It works very well as the cartridge-based, but then it has requires some degree of manipulation. Cartridge-based test requires no manipulation. Once you have put in the charge the cartridge, you put it into the machine, you get the results. The third test is LPA. LPA is much less sensitive. Advantages, you can get both INH and rifampicin together in a first line LPA, but can only be used in a smear positive. So you, therefore, in a child, your first test will never be an LPA because you are starting with an X-ray or screening. If you have seen a sputum which is smear positive, then only you can use an LPA. And therefore, we push it for a drug-resistant suspect or presumptive case, as Sangeeta mentioned. And as Dr. Sood brought out very beautifully, that this is not routinely available, everywhere available, and the yield is less. What is available to you is a TrueNat or a gene expert, and that works very well. So if you get the result from there, if it shows MTB detected, it's a microbiologically confirmed test. This NAT is a nested NAT. By nested NAT, we mean it gives you two information. It tells you that patient has, whether the specimen has MTB, and it also tells you whether this MTB is RIF resistant or not, with a specificity of about 90-95%. That's a good amount of specificity. So if you get RIF resistant detected upfront, since it's a child who may not have any epidemiological factors to suggest that this child is at a higher risk of drug resistance. So what are those epidemiological factors? If this child was a relapse, if this child was a retreatment, or if this child was from a contact of or exposed to an MDR case, or this child had a family history of death due to TB, then that's a DRTB suspect. Then your single specimen showing the RIF resistance is good enough. But if it is a child who is primary case, if the MTB load is high, it's still RIF resistant detected is perhaps reliable. But if it is very low MTB load, then sometimes there is disparity, and therefore you have to repeat the specimen. If only it is confirmed by the second specimen, then only you will treat as RIF resistance. The other possibility is that you detect MTB, but you do not detect RIF resistance, and that means this is RIF sensitive, and we treat accordingly. Another important thing to remember in our country, isolated rifampicin resistance is very rare. It is almost a surrogate marker of MDR-TB, that is R and H, and that's why all cases where you get a RIF resistance, you would treat them as MDR. In fact, you would investigate for other second-line drugs to see that it's pure MDR and not an XDR or a pre-XDR. If this child is NAT negative, which would be in about 50%, 55%, or sometimes 60% of your cases, that means negative gene expert does not rule out TB. So remember that. That's an important carry home message. So you would still have a situation that NAT will come negative. In that situation, there could be need for repeating the specimen because the quality of specimen is very important. So you could repeat from a better quality specimen or an alternative specimen like bronchoalveolar lavage or aspirate, depending on the availability or feasibility. Or sometimes these children, up to 30% of pediatric pulmonary cases, may have a palpable lymph node in the axilla or in the deep in the neck if you are careful enough to palpate. And if you will do an FNAC from there, that may give you a diagnosis. So remember to look for these contiguous extrapulmonary sites which are often involved. It's another case when they have a disseminated TB, then you have anyway would have found other sites. But I'm saying even in pulmonary cases, you often have lymph node involvement. And this is where if you still do not have access to another specimen or your repeat NAT is negative, then depending on where you are, you may seek review from a higher center, and higher center means a center which has a better capacity than you to work it up further. So this is our first limb. Our second limb is if it comes NAT positive, it goes there. If it is NAT negative, you have to rule out all the possible alternative causes. Ankit, can you press the next, please? And once they are ruled out, this is a child who will be called clinically diagnosed probable TB case and will be treated as RIF sensitive. If the X-ray shadows are non-specific, that means they are neither miliary nor adenopathy nor fibrocavitary pneumonia or inhomogeneous, shadow or scarring or some nodules or some bands here and there, inhomogeneous opacities, then it's hard to sometimes say that these are not atypical atypical pneumonia or a pneumonia which has been partly treated with an ineffective antibiotic. So therefore, you would like to use a course of appropriate antibiotics. You will definitely not waste time for 7 to 10 days of antibiotics if the child has already received a good set of antibiotic course, like with the comoxiclav or amoxicillin, and for 7 to 10 days, an appropriate antibiotic, in appropriate dose use. Then if it is persistent shadow with persistent symptoms, you will, in that case, also do a gastric aspirate and again follow the same circle. Remember, a NAT negative in a persistent shadow is a persistent pneumonia, which has many other differentials and therefore goes into the complete algorithm of looking for a persistent pneumonia workup. And that is where the seeking review from a higher center will again come. The third situation may be that your screening X-ray is normal. But this is a child where symptoms were suggestive of TB. Then maybe it is extrapulmonary TB, because systemic signs like persistent fever, weight loss could equally well be present with an extrapulmonary TB. So look for that. And then again, consider referral for a detailed investigation for an alternate cause or a TB, because remember, X-ray normal with same is, it just puts brackets them into a PU, and PU TB may be very common in our country, but is not the sole cause. So this is how this algorithm unfolds for our patients who have likely to have a pediatric intrathoracic TB. So major changes, you are starting as a screening with X-ray. Second important change is that we are going for a molecular diagnosis and we are repeating with a good quality specimen. We are priming with a course of antibiotic if it is a non-specific shadow. We are not wasting our time with antibiotics if it is a suggestive shadow. I have often seen patient with one month history, 3 weeks history, fibrocavitary pneumonia being pumped vancomycin, meropenem because there is high-grade fever or some neutrophilia. Don't do that. This is where you should have actually jumped to the fact that if this child is non-responsive, does not have any other pointers towards pyogenic infection, must be investigated for TB rather than just waiting another 2 weeks. So that's an important thing to carry home. All patients who are suspected of TB when diagnosed must also have an HIV test done. That's important. So this is what the current algorithm is. It comes with certain caveats, which I am sure the next slide will show. Dr. Ankit, please. So those caveats, I think we have omitted for in the interest of time, but most of them I had already addressed. Only thing which is relevant or missing is when we were doing smears, we were doing 2 specimens. When we are doing CB naught, we are initially doing 1 single specimen, repeating if only you still suspect TB with a better quality specimen. You are not routinely asking for 2 specimens as you were doing for AFB. So that's an important change. Thank you, Dr. Ankit.
So, once we have diagnosed a child as TB, so now, Dr. Sood, what regime, what drugs, and what doses would you use to treat this child?
As Dr. Virender has highlighted that we have now 3 categories. One is this, if we talk about this particular patient, this is a new microbiological confirmed pulmonary TB. Another is at times extrapulmonary. And then another category will be new clinically diagnosed pulmonary as well as extrapulmonary. And at times we have patient where there is a recurrence who were lost to follow-up and the treatment after failure. But here one important thing is to understand that this patient, once we reinvestigate them, they should not be having evidence of resistance to rifampicin. Otherwise, the protocol will change. For all this, we all know we have this set of 4 drugs to begin with, 2 HRJD, and then for next month we are going to have 2 HRE. And why this HRE, this ethambutol came, we must remember that Dr. Singh has already highlighted that we are having a good number of rifampicin resistance. So just take care of that. The ethambutol has been made a part of now treatment regime.
So all drugs are daily, and we have added ethambutol to the continuation phase. So it is not alternate day as it used to be.
As per NTP, now it is a daily dosing, and another advantage is now we are having fixed dose combinations, and with these 3 are dispersible tablet. And issue with the ethambutol is that it can't be made a dispersible, so it is a separate tab, and we want to discuss with the parents for the treatment of their children. And another highlight of NTP 2000 is that there is some revision of the doses now, because there were earlier issue that especially with the rifampicin, the earlier doses being used in twice daily or twice weekly and thrice weekly regime, the patient exposure was to mycobacterium, the drug dosage was not effective. So that's the reason that now we have moved to rifampicin in the range of 10 to 20, isoniazid 7 to 15, parginavir 30 to 40, and ethametol 15 to 25. And one more thing which we should right now know that this now algorithm is on weight band. Now it is not on age. And there's one more issue that it has been shown that those with the lean mass, probably they get less of in those patients, mycobacterium get less of exposure to the rifampicin. So there are few issues which has been highlighted by the WHO over last 10-12 years, and that's basically the basis for moving on to weight band. And this is a table is very well, so we should be having this, that how we have to continue from the intensive as well as the continuation phase.
So these FDCs are available from the National TB Elimination Program. Now there's a public-private partnership as well. So for example, in our hospital at BLK, there would be one representative from the NTP or its associate like GIT, and they would help to register the patient and provide drugs as well. A usual question, Dr. Sood, which is asked is that we do not have these FDCs available in private practice, and there would be a lot of patients who would not prefer to go to an NTP approved center, and they would like to buy these medicines. Then what should we do?
Probably there are 2-3 riders. One thing, when we are dealing with this page, before we initiate on the therapy, one must remember that notification of this case is very important as we move on to further therapy, because that's very important. And that's the reason that our colleagues in the private practice, probably they are not going to keep these medicines. And I don't know what is happening, because in my state, all patients are referred to the healthcare facilities, and only a few second line drugs are available only with 1 or 2 selected chemists, because there are no number of riders for the chemist to keep all these. They need to keep a photocopy of prescription, name of prescribing physician and everything. So in my state, all patients are referred to the hospital or government institutions.
Yeah, I think in Delhi, if the other option is to use single drugs, still we have FDCs available in the market as well. If the child is being referred to an NTP approved center, then obviously they will get the drugs, right? So we have heard that there is a current recommendation of pyridoxine as well, Dr. Sood. So can you just elaborate on that?
Yeah, this is another highlight from the previous guidelines in the NTP. Actually, this is, we all know that when we use INH in these patients, it's basically anti-metabolite of pyridoxine. So earlier, this was a recommendation was seen that you need to supplement only in the selected categories. Now there are 2 issues now. One, we have increased the dose of isoniazid to 10 to 15 milligrams. So probably that has also made more requirement of pyridoxine. So keeping in this view, and we have a good number of patients with malnutrition, or those may be having borderline. So just otherwise it is going to unmask the presentation of pyridoxine deficiency. So now it is universally recommended to use isoniazid for all patients in children in all cases, 10 milligram for infants and 20 milligram for children for whole of the therapy. Yeah, and another important issue that is not a costly drug; it's very cheap.
Right. So we got a history in this child that the grandfather actually died with tuberculosis 6 months back. We did not have papers, but the grandfather was already on some injectables as well. So, Dr. Sangeeta, would your approach to this child change?
Yeah, the approach will change, because now, though this patient is a new patient is any child who has not had prior ATT for more than 1 month. So it, any new patient without history of prior ATT of more than 1 month, if there is a history of tuberculosis in the family, or there is a death where you do not know the sensitivity pattern, or the child himself or herself is HIV positive, seropositive. So in those cases, you need to get further investigations done. Then also, if the child is already on treatment of more than 1 month and the child is not responding to the first line drugs, or there is a failure, that is what we call the failure, or his left treatment, that is lost to follow up, and the child comes back again to your facility, or there is a relapse, that is the child was declared cured initially, and but now the child has had a relapse of tuberculosis. So all these categories you need to work further. As you've already discussed, we need to get the CBNAT done. Now, if the CBNAT is positive, well and good. If it is negative, then we need to get the MGIT culture. MGIT culture is sent side by side for those who are NAT negative. Now, based on the NAT report, if the NAT shows RIF resistance, as Dr. Virinder has very rightly pointed out, that RIF resistance in a child, if you are sure that the sample is adequate in a new patient, then it is taken as RIF resistance. But for a patient who's already had prior ATT, even a single specimen positive is taken as RIF resistance, and the child is offered now not only second line LPA, but also first line LPA. I'll tell you why. So the first line LPA is because now the regimens they have defined as separate. You have a regimen for RIF resistance, which can either be a short regimen, short MDR-TB regimen, or a longer regimen. So to fit the child into a shorter MDR-TB regimen or a RIF resistance regimen, you need to have a child who is INH sensitive, and also the second line LPA will tell you about the fluoroquinolone and second line injectable sensitivity. So such a child can be offered the shorter regimen. And the second line LPA, if it shows that the child has fluoroquinolone and or second line injectable resistance, then there is a separate regimen. That child is labeled as pre-XDR or XDR, depending upon if it is either of the two, it is pre-XDR. If it is both together, that means fluoroquinolone resistance along with second line injectables, that is labeled as XDR. Now coming to, this was for a child who was diagnosed based on the NAT with RIF resistance. Now, if the NAT report shows RIF sensitive, now in the prior days, we were leaving it till there, but not now anymore. We move further. We get again, we need to get the first line and the second line LPA, because the child would be eligible for the regimen which Dr. Sood has discussed for a new patient, that is 2 RSZD, 4 RHE. But a separate regimen exists for only INH resistance. And further, the second line LPA is done because the child with INH resistance may have polyresistance. That means may have added resistance. So that is the flow chart. So to cut short and to base on the memory would be, you need to get a CBNAT done first. Based on the report of the CBNAT, if the CBNAT is negative, simultaneously send the specimen of a negative for MTB culture, put the patient, then you have to wait for the CBNAT culture, and you can start your first line drugs if the child is a new patient, as we've already discussed. But if the NAT is positive, shows RIF resistance, then you, or RIF sensitive, in both the scenarios, you need to get first as well as second line LPA done. And liquid culture is preferred because in case your patient is not responding, that's another scenario. Liquid culture will guide you further. You can get a liquid DST for all the drugs, or after liquid culture, you can get a line probe assay on the culture. So this is how the regimen would flow now.
So, as Dr. Sangeeta said that in few of these situations, you would classify a child as a presumed ARTB, as already mentioned. If that is the scenario, then you cannot decide on drugs like that. You have to further investigate. The first investigations upfront, which means before you start treatment, you have to get a NAT and an MGIT culture has to be sent, and then you further classify it as rifampicin resistant or rifampicin sensitive. And further, as madam has said, we have to see whether the rest of the drugs would be sensitive or resistant to decide the regime. It is a bit complex. We do understand. I have specifically put this not to confuse people, but just to let people know that how we evaluate these children, because you will come across these sorts of children in your practice. If at that time you feel you're not comfortable investigating them, we would recommend that you can refer these children, but do not put them on ATT without further investigations. Right. So we'll go on. So Dr. Singh, can you briefly tell us that what are the new drug-resistant treatment regimes, just to let people know that something has changed here as well.
Thank you, Ankit. Before I go take you through this table, let's quickly understand the essence. Okay. The essence was, in the past, we were treating everyone as presumed drug sensitive. So there was a category 1, which was RHZE, to which an E was added in the continuation phase later on because there was increasing INH resistance in the country. So we had RHZE for 2 months, followed by 4 months of RHE, which was 10 months of RHE for intracranial. We also had a category 2, which got removed once E was added for 2 reasons. We realized that if you were presuming drug sensitive in every case first time, and because the facilities for drug resistance was not available, treat them with addition of streptomycin, we were actually amplifying resistance to rifampicin and other drugs, and that was harder to treat. In the meantime, these nucleic acid amplification tests came to the country, which made it easier. Earlier, we had solid cultures. It would require you 12 weeks to 24 weeks to get a culture. It was not easy. Even in the state of Delhi, there were just 2 labs which were doing it. So it was just not possible. We were doing everything empirically. And therefore, we were gradually increasing the MDR-TB in the country. With the result that we now have a change, and now we are looking at picking up any resistance early enough. So if you have identified RIF resistance, you presume R and H, and therefore thereafter you decide for MDR therapy. But the moment you decide that MDR therapy, you want to be equally sure that the drugs which you are replacing the initial regime with are effective. And therefore, there comes the role of first line and second line LPA to know what kind of resistance to INH is there, what kind of resistance to fluoroquinolone or second line injectable is there, so that you do not use the drugs if they are also resistant to these. In our country, deficiency of fluoroquinolone or deficiency of ceftriaxone in the body results in fever. I'll give you time for this joke to sink in, because that's how we treat most of our PUs. Every pyroxia of unknown origin is either treated with a ceftriaxone injection or oral fluoroquinolone or a cefixime. So we therefore have a high level of background resistance to these in MTB. So we therefore cannot again use standard MDR therapy without looking for these resistance, and molecular methods have made it possible for us. So with this background, let me take you to the regimens. Now, since there are many drugs available, initially we were using injectable therapy. Injectable therapy is 4 to 6 months of injection, not easy in a small child, even in an adult. Great risk of ototoxicity. So gradually now, with the availability of new drugs like delamanid or bedaquiline, we want to withdraw and go to all oral. However, age becomes a limitation. you cannot use, till now in our country, we are not authorized to use bedaquiline, which is a new oral drug below 12 years, or delaminate below 6 years. Therefore, you have a regimen for below 6 years forced on you because there is no drug available which is non-injectable. The combination which is now available, which is recommended, is what is also called as short regime, or called as Bangladesh regime or Dhaka regime, because that's where it was first tested. Very often in our country, we call it is a short regime, which has high dose moxifloxacin, kanamycin, ethanoamide, clofazimine, and paracetamide with high dose INH. When we say high dose INH, we mean 15 milligram per kg minimum, and ethambutol. This is for 4 to 6 months, and then for next 5 months, you take off kanamycin and ethanoamide and high dose INH. That you do not use, and rest continues. That's the idea. Imperative in this is that this patient should not be also harboring resistance to either fluoroquinolones or second line injectables or INH, which is both to CAT-G as well as INH-A. These are two different mechanisms by which INH resistance occurs, because when you have both CAT-G and INH-A, you will also lose ethanoamide. So your regimen will become weak. So that is why these patients need to be further tested for first line and second line LPA. If it is a difficult to reach specimen, you must upfront send that for culture. Otherwise, once your gene expert shows RIF resistance, you ensure you send another sample, you treat with this, and as soon as you know about the presence of other resistance, you have to change. If this child, and this regimen is not recommended for a disseminated disease, intracranial or extrapulmonary like a spine. That's not where it is recommended, because it's too short a regime to be used in those situations. So it's not recommended there. So even if you are below 6 years, if you have any of those diseases, you will not get this. This is only if you are below 6 years and you have isolated EP like an abdominal or a lymph node, or you have a pulmonary or pleural effusion. That's it. If you are more than 6 years and you have not a disseminated disease, not a severe extrapulmonary disease, you can, instead of injectable, get delaminate or bedaquiline if you are more than 12 years. So injectables go. And here, what is also added is linezolid and clofazimine along with cycloserine. This regimen is about 18 months. Here in the continuation phase, you do not use delaminate. Rest of the drugs are continued as it is. It's just the dose of linezolid will go down because it is there is a risk of increased toxicity with prolonged high dose of linezolid. It can suppress bone marrow. It can sometimes cause ocular toxicity. However, if you have a disseminated or severe extrapulmonary disease, irrespective of what age you are, you can only go on the conventional regime because newer drugs have not been tested there. You cannot get on a shorter regime because they are too short. So you go on a conventional regime, which has an injectable, which has a class A drug like high dose moxiflox with linezolid, which is another class A drug, and class B drug as cycloserine and clofazimine, and ethanoamide and amikacin come from class C. So there is a grading of the MDR therapy. More you see use from a higher class, better it is. You need at least 4 drugs from class A and B. And that's how we constitute this regimen for disseminated disease. This is at least for 24 to 28 months, which you will get. There is another fourth type of regimen, which is not for RIF resistance. The first 3 which I have talked to you so far were for RIF resistance with or without fluoroquinolone or the type of disease they had, or like pre-XDRs. But this is a regimen which is if you have INH resistance. Earlier we were saying if you have INH resistance, you could be managed with a combination of first-line drug. Now evidence suggests that's not true. They tend to relapse more often and or fail more often. Therefore, INH is replaced by a levofloxacin. This is where Dr. Sangeeta also mentioned that since you are replacing one levofloxacin, you know about rifampicin. Ethambutol is difficult to test, but you need to know about fluoroquinolone, paracetamide, that they are not compromised. So you will therefore also continue to test this patient where you have identified INH resistance, whether they are sensitive to fluoroquinolones, and paracetamide. Otherwise, that patient will also go to a complicated regime like the earlier one. These will need replacement. There is a very detailed replacement chart which is available. I think you don't need to know that. That's to keep people like Sangeeta and me in business. No, that's not the only reason. That's also because it's a starting point. We do not want to give you so much of information that you get confused. Remember that there is a modification of these regimen which is required. Those charts are easily accessible online. You can do it yourself, or you can always seek help from experts available in your area. So these are the new initial drug-resistant regimens which are available to us, which we should be using.
Last 2 to 3 minutes.
The timer says 12 minutes, ma'am.
Yeah. So maybe some questions will come in the chat box.
Okay. So I'll just try and wind up in the next 3 to 5 minutes. So very rapid fire to the point answers. So if we believe that this child is drug sensitive, what are you going to do about the contacts? Dr. Sangeeta, please.
Yeah, now the context would be based upon the symptomatology. If the child has symptoms, then obviously you need to rule out active tuberculosis. If the child is asymptomatic, then if the child is less than 5 years, you start LTBI management. If the child is more than 5 years, in that case, you need to counsel the parents that the child requires IPT, and you can do testing for infectivity, that is IGRA or MONTU, whichever is available, and offer the child again IPT. Now the crux is that we want if we want to end tuberculosis globally, emphasis has to be on the prophylaxis therapy, because one of the pillars is that we need to put 30 million children and adults on IPT.
Okay, so there's a bit of change, as Madam has said in the algorithm, that now the government of India and the IAP has also included children more than 5 years for chemoprophylaxis, and that goes by the recommendation of the WHO as well, because the risk of having TB in close contacts, even in more than 5 years, is significantly high. So this is something which has been advocated, and yes, we are moving towards TB elimination. So, Dr. Sangeeta, is it mandatory to do a lot of investigations, or
no? Not really. Okay. Symptoms are fair enough. The only thing is that you need to rule out active disease if the child is having, the 4 symptomatology, that is fever, cough, the presumptive TB patient, which we had already discussed, or a child, a newborn, where the mother is sputum positive, and you need to rule out active disease and put the child on prophylaxis only after being sure that the child is. The other is HIV. HIV, you need to rule out active disease, but irrespective of the CD4 count, you need to start the prophylaxis, or whether the child is on ART or not. Prophylaxis with IPT. Now the combination is available for HIV, where you have the drugs available. And the other thing is for any child who's to be put on immunosuppressive therapy. As in children, you have nephrotic syndrome, leukemia. In those children, all TST positive who are receiving immunosuppressive, you need to rule out active disease, obviously. And if the child is asymptomatic, put the child on PPT, that is prophylaxis therapy. And as I've already discussed, if the child is born to a mother, the most important is if the mother is sputum positive, she needs to continue breastfeeding, wearing a face mask. That needs to be really told to the mother. Put the child on INH prophylaxis and give BCG vaccination.
So, Dr. Sood, this child,
and now, this 6 months of INH would be in future replaced with a shorter regimen, which is going to be intermittent. But for that, the child age has to be more than 2 years. That is rifampicin and INH weekly. So total 12 doses, 3 months.
So Dr. Sood, very
So
briefly,
that's
this
it.
child now develops vomitings after around 10 days, 2 weeks. So what would you do?
Same, we are dealing with the drug-induced liver injury, and we should remember this is just a presentation like as we see in the prodrome of viral hepatitis A. So this is important to understand, and definitely as you already shown, so we need to order for liver enzymes and liver profile, and it is shown that most of the time ALT is above 500, and the AST may not be so much rise, so that probably qualifies, and invariably there is associated bilirubin also, which is range beyond 2. So that's basically now the purpose is once we see this patient, then two things are very important. One, we need to stop all this regime which is there, because this is invariably seen during the first fortnight. Rarely a patient can present late also. So we take ALT 5 times or less than 3 times, and then if another rider is that if patient is sick, as you have already shown, then you need to start with 3 drugs like streptomycin, ethametol if patient is very sick, and if patient is stable, then we can wait for 7 days and repeat ALT after 7 days, and most of the time 99.9% it will start coming down, and then we need to introduce gradually drugs. Rifampicin after 3 days, do more assessment, then add on INH in full dose, and after 3 to 7 days do, and then add on pyrazinamide. But there's one rider. If ALT remains more than 5 times higher than upper limit, then one need to take care of pyrazinamide. Otherwise, the toxicity will be higher. So you need to modify the regime. And as Dr. Singh and Dr. Sangeeta sharing, you need to consult a person who is dealing with this sort of patients.
So with that, we end the questions which we have made, and I think we can take a few questions from the chat.
Yes, so there's one question in the chat box from Dr. Manish Gupta, that what is the current percentage of MDR TB amongst pediatric TB patients, if we have any data?
You see, the national average is for rifampicin or MDR is less than 5%. Okay, but if you go to pediatric, perhaps we have seen most of the studies where when we looked at gene expert positivities, it comes to about 7 or 8%. So there is a bias also there, because the children also get a lot of transmitted disease, and it's not just the background which comes from the initial resistance which is there in children, in adults. So possibly we're talking about 5% resistance here in terms of an MDR. There are pockets like Sikkim or Bombay which have very high resistance, up to the extent of 20 or even more percent there of MDR, primary MDR. So in our rest of the country, we are close to about 95% are RIP sensitive. INS resistance is to the tune of about 15 to 30%. It varies at different areas.
Even fluoroquinolone resistance. So that also gets us to the answer that we need to seriously not use fluoroquinolones for any infection which can easily be treated with amoxicillin or other drugs.
Rather, Dr. Sangeeta, they are not recommended fluoroquinolones. It's only the amoxicillin, you rightly said. And as Dr. Singh was saying, I just want to add on, ceftriaxone is now being misused for all patients with COVID.
Yeah.
This is the first shot they get in any facility when they enter, ceftriaxone.
One more question from Dr. Manish. You want to ask Dr. Manish, or shall I just read it out?
You can ask Dr. Tapisha.
So the question is it okay to follow the pediatric TB algorithm and not to do tuberculin skin test, as availability of right strength is an issue?
You see, we struggled with tuberculin skin test because we don't have the right strength. We do not know what it tells us. And we have been chasing it for a long time. Having said that, it does still have a little role, and the role comes when your molecular test fail you, and you have a standardized test available. It will have a role. But currently, in today's time, if it is done, instead an IGRA is done and it comes positive, maybe you can use it. But then that's expensive. in in high burden, low resources country like ours, it hasn't been shown to be any good replacement of a tuberculin skin test. If COVID had not come, perhaps Serum Institute would have been in news for producing the Copenhagen new TB skin test called CTB, which they have acquired the worldwide rights, because now they have become busy with COVID vaccine that's taken a back seat. So in a similar session last year, we were saying we are around the corner to get CTB in India. We are 1 year down the line, it's nowhere in the picture because the company is not even today talking of it. So therefore, we have removed it from the current algorithm because we do not have a standardized test available. The utility remains more out of loyalty to an old partner rather than an actual value addition it brings.
But definitely in cases of LTBI, sometimes, it would help.
LTBI is a different thing. LTBI, there is no other test.
So there's one more question from Dr. Shalini. Can quinolone containing regime be used for MDR TB with neurotuberculosis?
Yes, we are using high dose of levofloxacin or moxifloxacin. They cross and they are useful.
In fact, they are one of the first, as Dr. Vrinder said, they belong to the group A drugs, and you need to include maximum group A and group B. Group A, that is bedaquiline, which we cannot use. So the crust comes on moxi or levoflox with linezolid, and group B is cycloserine and clofazimine. So these are the major crusts of the MDR TB regimen. They need to be included. The only thing is, as Dr. Vrinder said, this child would not be eligible for a shorter MDR TB regimen. Same would be a child who is seropositive, that is HIV positive with any extrapulmonary TB is again ineligible. And if the child has had a prior history of ATT of more than 1 month, that is reserved drugs of more than 1 month, that child would also not be eligible for shorter MDR TB regimen.
Ma'am. One last question from Dr. Prashant Seth, which is, what is the role of linezolid in MDR or XDR tuberculosis? Is there a role?
I had shown in the documents that linezolid is a class 1 drug and they are being used. It's just that the first regimen which I showed you, which we call as a short regimen, it has only been tested in that combination. As I said, it's a Bangladesh or Dhaka or short-term regimen. There no replacement is permissible. We do not replace any drug with any other because it has not been tested. So linezolid therefore doesn't find a place there, because when that was tested, that regimen was tested, linezolid was not established as an anti-TB drug. It came little later. And that is used for with other combination. And as Dr. Sangeeta mentioned, that it's a class A drug and therefore recommended, strongly recommended.
Thank you, sir. And so over to Dr. Ankit for summarizing, and then we close the session.
Yeah, so I think we're running short of time. When we do a 2 days panel, even then the questions don't end. So it is a burning topic. So I thank all the panelists, Dr. Singh, Dr. Sangeeta, and Dr. Sood for a very nice discussion. We thank the PCNI team for inviting us here. If you have any more questions, you're most welcome to ask any of us. So thank you and have a great day.
Thank you.
Thanks, Dr. Ankit, and thanks to the entire panel for such a lovely session. And can you please stop the screen share? And now we'll go on to the next session. And the next panel discussion